Sorry about this, Charlotte.
That's fine. Take your time. I'm not stressed by time.
You can tell I'm an audiologist and not a YouTuber. Right.
Well, that's an issue for all of us, really,
Yeah.
even though it's been 5 years.
Right. Let's see if this works. If it doesn't, then I will be able to just record it at least.
Normally, what's the attendance rate?
We normally get like 10 to 20 live and then obviously more afterwards. So I'm going to start now and see what happens. Welcome to our patient education program hosted by Hashir International, Specialist Clinics and Research Institute for Misophonia, Tinnitus and Hyperacusis. Each month, we're exploring a different topic within sound sensitivity, aiming to give you a broader knowledge and understanding of these conditions. My name is Joanna Barker, and I'm your host for these sessions. I've been an audiologist for the last 12 years, and I'm a specialist in misophonia, tinnitus, and hyperacusis. Today, we're joined by Charlotte Bigras, audiologist and PhD in hearing sciences from the University of Montreal. She specialises in the sensory and affective perception of sounds, including conditions such as hyperacusis and tinnitus. Her research focuses on the cognitive and emotional mechanisms of sound perception, with a particular interest in sound therapy and mild traumatic brain injury. Charlotte is kindly sharing a presentation with us which examines how two tools, the hyperacusis questionnaire and the noise sensitivity scale, help us understand sound tolerance issues. By comparing their use in healthy adults and veterans, it reveals important insights into the overlap and differences between hyperacusis and noise sensitivity, shedding light on these often misunderstood conditions. There will be the opportunity to ask questions after the presentation, so please feel free to post these through the chat function. Thank you so much, Charlotte, for joining us. I will now hand over to you.
Well, thank you, Joanna, for the introduction and for inviting me. I will share my screen. Is it the right one? I'm not sure. No.
Yeah, that's perfect.
I think it's this one. Okay. Can you see my screen?
I can, thank you.
Good. Okay. Well, it is a pleasure for me to be here today and contribute to this patient education program, which I find extremely useful and relevant to patients and also clinicians. So to briefly introduce myself again, I am a clinical audiologist from Quebec, Canada. I've been doing research on tinnitus and hyperacusis for close to 10 years now. I just finished my PhD on the subject of hyperacusis specifically. As part of my thesis, I worked on this study, which was published just last year in 2024. The title is Noise Sensitivity or Hyperacusis, comparing the Weinstein and CALFA questionnaires in a community and a clinical sample. First, I'd like to acknowledge my co-authors, Sarah M. Theodorov and Emily G. Tillman from the National Center for Rehabilitative Auditory Research in Portland, Oregon, USA, and Sylvie Hébert, full professor at the University of Montreal, and my dear PhD supervisor. I sincerely thank them all for their work and support throughout this project. So I'm happy to share with you today our results and give you some insights I've gained from this study and from my PhD work in general. As an overview, I will introduce what are decreased sound tolerance conditions, some available clinical tools we have, the methodology in our study, key results, the clinical implications, the remaining unanswered questions, and our next steps. Decreased sound tolerance conditions include, but are not restricted to hyperacusis, noise sensitivity, misophonia, and phonophobia. This is probably not the first time you hear of these terms. You may have also heard of other synonyms such as auditory sensitivity, sound intolerance, hypersensitivities, and others. The terms and definitions might vary according to different sources, And the reason for that is that there is still a lack of consensus among researchers and clinicians about the right terminology and distinctions between these conditions. For today, we will focus on hyperacusis and noise sensitivity. I will start by describing to you my understanding and working definitions of those two conditions. First, what is hyperacusis? I like to use a visual example. So imagine you are turning the volume control or volume dial to listen to your music. If you have normal hearing without hyperacusis, you start hearing music from early on the dial at the green line, and you can enjoy your music at low, medium, or very high volume. You only feel discomfort when the volume is very, very high at the red line here. So you have a wide range of intensities to enjoy your music. Meanwhile, with hyperacusis, you also hear the volume early on the dial, but your tolerance threshold is much, much lower. See the red line here? So around the middle of the volume control, the sound already feels too loud. So you have less space, less range to enjoy your music comfortably. And how would this manifest in real life? Well, as you may know, it is hard to avoid loud sounds in our modern society. Hyperacusis can lead to significant distress, functional impairment, overprotective behaviors, and social isolation. Now, hyperacusis discomfort is different from the discomfort caused by hearing loss. Here, you need to turn the dial much, much higher, much longer before you hear anything. But once you hear your music, your threshold of discomfort, the red line here, comes very fast. This means even a small increase can quickly feel too loud. Again, the comfort zone is small, but this is for a different reason than hyperacusis. That said, it's also possible to have hyperacusis with hearing loss, which might lead to an even smaller range of comfort to listen to your music. All of this to say that this simple visual example is to show what pure hyperacusis might look like according to recent definitions, where any sound that reaches a certain volume becomes unbearable. But of course, as you may know, it's often more complex than that in reality. Other factors like the type of sound, the emotional state of a person, or the context in which the sound is heard can all influence how someone reacts to sound. Now, maybe this is the first time you hear of noise sensitivity. We don't talk about it much in audiology, but it is starting to get more attention. Originally, noise sensitivity stems from psychology research. And noise sensitivity is about how much a person can tolerate ambient noise, regardless of its volume. It has been considered a personality trait, but it also could be acquired after a traumatic brain injury, for example. People who are noise sensitive often notice sounds more, feel more annoyed or overwhelmed in presence of noise, and have difficulty getting used to noise. We could imagine noise sensitivity like a normal curve distribution, meaning in the overall general population, some people have low noise sensitivity, most people are in the middle and have moderate noise sensitivity, and a small group of people has high noise sensitivity. But it is yet unclear if and when this high noise sensitivity group has a pathological medical condition that would require intervention. To wrap up, hyperacusis would be when everyday sounds become unbearable at a certain volume, while noise sensitivity, this is when someone has difficulty tolerating noisy environments, regardless of volume, leading to feeling generally annoyed or overwhelmed. If you think about it, it's true that some people feel really annoyed by noise, even though it can be very soft. I have seen patients where they are not necessarily bothered by loud sounds, but rather by low constant noise, such as a washing machine turning, the dishwasher, or the traffic noise by the window. But in clinical work and research, we don't always separate noise sensitivity from hyperacusis, but maybe we should. Noise sensitivity and hyperacusis are often confused because research papers don't always clearly define them. Both conditions involve discomfort with sounds and similar behaviors like avoiding noise, wearing ear protection, and feeling anxious. Since we don't fully understand how they work biologically, some researchers treat them as the same condition, while others see them as separate but with overlapping symptoms. Another reason for the confusion between hyperacusis and noise sensitivity is that we don't have reliable measures for either condition. Among the available clinical tools we have, there are self-reported questionnaires, such as the Hyperacusis Questionnaire, which acronym is HQ, and the Noise Sensitivity Scale, or NSS. If you consulted an audiologist, you might have completed such questionnaire where you answered questions such as, are you easily bothered by noise? On a scale from no, yes a little, to yes a lot. Such questionnaires help us clinicians get a better glimpse at the severity of your problem. We can sum up your answers into a total score, which we can compare to established norms. We can also use this score to follow improvements during treatment, meaning that a reduction in score, for example, could indicate to us that a treatment such as CBT or sound therapy was successful. The HQ is a 14-item questionnaire where the patient answers each question on a scale from no, yes a little, yes quite a lot, to yes a lot, with a maximal score of 42. You can easily find this questionnaire online. The HQ was created in 2002 by Stéphanie Calfa, a doctor in neuroscience, and her team in France. It was published in an ENT journal. Its purpose was to quantify and evaluate hyperacusis. It was built on recurring themes and hyperacusis surveys and specific populations like veterans with hyperacusis. It was developed within a random selected sample from the general population, mostly university students. It is by far the most used hyperacusis questionnaire in clinical audiology. Various clinical cutoff scores were suggested through the years. For example, if you get a score at or higher than 22, 26, or 28, you would reach a clinical score for hyperacusis. Even though the HQ is the most used, it has been repeatedly criticized for not accurately measuring hyperacusis, but mixing it up with other auditory conditions. For example, if you look at question number 5, it tells you, do you have difficulty listening to conversations in noisy places? Well, if you have hearing loss, you might respond with yes a lot to this question without having hyperacusis per se. And yet you will still get a high score on the HQ and maybe categorized as having hyperacusis. And that is exactly what is being criticized and a limitation which we will come back to. Next, there is the NSS, which is a 21-item questionnaire where you have to rate on a 6-point Likert scale. At what point do you agree with each sentence for a maximal score of 105? For example, item 1 says, I wouldn't mind living on a noisy street if the apartment I had was nice. The NSS was introduced even earlier than the HQ in 1978 by a psychologist named Neil D. Weinstein in the US. It was published in the Journal of Applied Psychology. Its purpose was to measure self-reported noise sensitivity and associated emotional reactions. This questionnaire was developed with a community sample of college students to measure how they were sensitive to the noise in their dorm rooms. It has been mainly used in community settings and research, including academic settings, transportation-related noise, and sleep disturbance studies. Already you can see that there are noticeable differences in how the two questionnaires were developed, given that they emerged over more than 20 years apart and in different realms of research. And yet, some questions do look very similar, such as the question 4 of the HQ, do you have trouble concentrating in noisy surroundings, is similar to question 14 of the NSS. I'm good at concentrating no matter what is going on around me. Or question 14 of the HQ, do noise and certain sounds cause you stress and irritation, is similar to question 10 of the NSS. Sometimes noises get on my nerves and get me irritated. So audiologists have been using the HQ, while psychologists and urban planners have been using mostly the NSS. This prompts the question, do these questionnaires measure the same thing? And more generally, are hyperacusis and noise sensitivity one and the same condition? This brings us to our objectives, which were to first examine HQ and NSS score patterns and correlation in clinical versus non-clinical populations in order to provide normative data for clinical applications and future research, but also to determine how people who self-report decreased sound tolerance compare on the HQ and the NSS, and more generally, to explore distinctions between hyperacusis and noise sensitivity. Regarding methodology, 2 samples of participants completed both the HQ and the NSS. First, in Montreal, we had the non-clinical sample. We recruited 103 young adults of about 28 years old with normal hearing to mild hearing loss. They all completed both questionnaires, and 9 of the 103 participants self-declared decreased sound tolerance. We then collaborated with the National Center for Rehabilitative Auditory Research, which is part of the U.S. Department of Veterans Affairs, VA, in Portland, Oregon. Their team recruited 95 veterans with or without comorbidities, such as various health problems or injury to the head or neck. They were about 52 years old, with mild to moderately severe hearing loss. And in their case, it was 59 participants out of 95 that declared decreased sound tolerance. We then calculated the HQ and the NSS scores of each participant within each sample. As for the results, we got for our non-clinical sample in Montreal and the sample of young adults, how to read this graph. Well, on the horizontal axis, you can see the HQ scores from low scores, meaning few hyperacusis symptoms, to high scores, meaning a lot of hyperacusis symptoms. And on the vertical axis, you have the same thing, but for the NSS score, meaning at the bottom, low NSS score would mean few NSS symptoms, while high score at the top would mean a lot of noise sensitivity symptoms. Each circle and each cross represent a participant at the intersection between their individual HQ score and their individual NSS score. What we can see is that the more a participant has a high score in the HQ, the more they also have a high score in the NSS. And the inverse would be also true. A high NSS score is associated with a high HQ score. This correlation between the questionnaires is qualified as strong with a correlation coefficient of 0.74. Also, you can see that there is 9 red crosses that represent the 9 participants that self-reported decreased sound tolerance. You can see that they scored high on both questionnaires, which we could interpret as them having more severe symptoms of hyperacusis and noise sensitivity. But next we have the same graph, but for the clinical sample of 50 years old US veterans. There again, it seems that when a participant has a high HQ score, they tend to also have a high NSS score, but the relationship is less strong. There is much more variability in the scores. Some participants, like this one, have a high HQ score, but a low NSS score. And other participants, like this one, have a high NSS score, but a low HQ score. This correlation was qualified as moderate with a correlation coefficient of 0.58. And again, the 59 DST participants, the 59 red crosses we can see for the 59 participants that self-reported decreased sound tolerance, they tended to have higher scores on both questionnaires compared to their counterparts who did not self-report decreased sound tolerance. So to conclude, both samples showed a similar trend, meaning people reporting decreased sound tolerance tend to have higher scores on both questionnaires, but there is much more variability within the clinical sample, which could be explained by the profiles of this clinical population being more diverse, particularly with their comorbidities and hearing loss. So what does this mean? What are the clinical implications? This was the first large-scale study using both HQ and NSS questionnaires at the same time within the same participants in two large samples. And we found a moderate to strong correlation between the HQ and the NSS score in two very different groups of people. They were differing in terms of age, hearing ability, general health, occupation, language, and nationality. This suggests that the questionnaires overlap a lot in what they measure, which makes it harder to clearly separate out what is hyperacusis from what is noise sensitivity. This is in line with what we observed before, that some items in both questionnaires do look a lot alike. Well, this raises concerns about the validity of both questionnaires. Do they really measure what they intended to measure? We know the HQ has been criticized for having questions relating more to the hearing loss than to hyperacusis, as we saw. Also, the definition of hyperacusis has certainly changed since 2002 when DHQ was first introduced. And notably, it is not clear if the HQ considers the notion that for hyperacusis, all sounds become unbearable at a certain set volume. It is not clear if the HQ considers that notion. But importantly, the HQ and the NSS do not measure the same thing. We saw in the clinical variance population that some participants could have a high score on one questionnaire and a low score on the other. But at this point, we can't say with certainty, indeed, this participant has hyperacusis, but not noise sensitivity. We just know that these questionnaires overlap, and only to some extent. This also means that these questionnaires are not to be used interchangeably, meaning you can't replace one with the other. As a clinician, you might want to consider using both and analyzing the individual item per item responses to see what is really the problem of your patient. This means the total score we sum up is just an overview of the condition severity, but individuals' item responses in a more thorough clinical interview might inform you in more details on what is the problem. Is it that my patient finds that sounds are too loud? Is it too noisy without necessarily being loud? Or is it that my patient has difficulty hearing or concentrating in noisy environments? It could be one or a combination of these complaints. And this sub-classification could allow for more targeted treatments accordingly. So this brings us to a need to better distinguish hyperacusis and noise sensitivity. Also, I invite clinicians who are interested in using these questionnaires to refer to our now published normative data. And here are some unanswered questions that remain and which I endeavor to get answers to in the coming years. So first, are hyperacusis and noise sensitivity part of the same spectrum or distinct conditions? I am leaning more towards two distinct conditions, but it remains to be proven. And second, what criteria distinguish normal noise sensitivity from a pathological condition requiring diagnosis and treatment? To do that, we need to identify pertinent biomarkers or behavioral indicators. And third, what role does central gain play in both conditions? Central gain is the most popular mechanism to explain hyperacusis. According to this hypothesis, central gain is the brain's way of compensating for reduced auditory input. So you imagine the brain turning up the volume when it thinks it's not getting enough signal. In hyperacusis, central gain may become dysregulating, amplifying sound signal excessively and causing pain or discomfort. While in noise sensitivity, central gain might interact more with emotional centers, or there might be entirely other mechanisms at play there, notably regarding the ability of the brain to filter out unwanted noises. Finally, would hyperacusis and noise sensitivity require different treatment approaches? Well, if we agree on different mechanisms, then yes, we should have different approaches. Sound therapy and CBT might work well to recalibrate central gain in hyperacusis, but other avenues like mild amplification or noise cancelling might work better for conditions such as noise sensitivity. So what are the next steps? Well, first, we need to reach a consensus on terminology and the clinical manifestations of hyperacusis and noise sensitivity. The next step is definitely to conduct a more thorough psychometric analysis, which was not our end goal here. But as we gather more data, we will be able to do more advanced statistics to verify the HQ and the NSS measure what they intend to measure. And if not, how can we move forward? An alternative would be to validate or develop more recent questionnaires. So remember that the HQ was created in 2002 when hyperacusis was barely studied, and it was first validated in a non-clinical sample composed mainly of university students. The author, Stephanie Kalfa, was a true pioneer, and the HQ has been useful for over 20 years. But today, with more precise definitions, it may no longer be the best fit. And for alternate newer questionnaires on hyperacusis, you can look up the HIQ, Hyperacusis Inventory Questionnaire, and the SSSQ, the Sound Sensitivity Symptoms Questionnaire by Hayes and al. 2022, or the IHS, the Inventory of Hyperacusis Symptoms by Greenberg and Carlos in 2018. As for the NSS, it is currently ongoing an international multi-language validation. So it will likely continue to be used in a lot of contexts. Another idea to distinguish hyperacusis from noise sensitivity is to use psychoacoustic measures. In my thesis, I created a task where participants rated both the loudness and the pleasantness of sounds. This type of task could help us see whether people with hyperacusis or noise sensitivity react more to the intensity or to the emotional content of the sound, and what's specific to each condition. It would also be important to validate physiological objective measures to answer questions like how does the brain or how does the body of someone with hyperacusis or noise sensitivity versus someone who has not these conditions? How does it respond to disturbing sounds? This could help us better understand the causes, mechanisms, and improve treatment for both conditions. Then the next step will be to study tailored treatments, such as sound therapy and CBT for hyperacusis. As for noise sensitivity, well, as I mentioned, we have really not much data on what would be the best approach, nor when is it necessary to intervene. But by continuing along these lines, we can improve how we identify, understand, and treat these conditions to ultimately help patients more effectively. Here are the references cited in this presentation. I thank you for your attention. I welcome your questions and feedback. And here is my current email, so please feel free to reach me anytime. Thank you.
Thank you so much, Charlotte. That was brilliant. I have a few questions for you, if that's okay. How you say that obviously we need to come to a consensus over terminology. How do you is that part of your next part of your research, or how do you have any sort of proposals on how we can do that?
Yeah, well, I have a lot of ideas. My next steps would definitely to find an objective marker or better ways to distinguish what are the manifestations of hyperacusis versus noise sensitivity. And in my thesis, I proposed this paradigm where you can study loudness from a sensory perspective. Like, do you find the sound that's too loud, not loud, too loud? And from an affective dimension, do you find the sound to be pleasant or to be unpleasant? And I will also like to add a cognitive dimension. So is the sound, is it hard to hear? And how does the hard of hearing aspects affect your sensitivity to noise or your hyperacusis? So that would be my approach to look at those three dimensions and see what's the bigger aspects in each of these conditions to better clarify the manifestations of hyperacusis versus noise sensitivity. And my hypothesis would be to continue in the direction that from the proposed definitions of the classification by Henry and al. In 2022, where it suggested that hyperacusis is mainly driven by this sensory aspect. So, as I was saying, hyperacusis is when all sounds become unbearable at a certain volume, whatever the sounds. So this would be the purest definition that we would use. As for noise sensitivity, it seems more of a complex concept where we would need to define, well, what are the, is it that it's hard to hear that causes the noise sensitivity, or is it really an emotional component that makes you hate the sounds, particular sounds? So yes, that was, I don't know if that was clear, but that was me. That would be my approach. And I was talking about objective measurements. So I truly believe that looking at mechanisms would help us understand better what distinguish those two conditions. But definitely they have symptoms that overlap, as we saw with the correlations in those questionnaires.
Yeah. Charlotte, can I get you to just take down your presentation? Is that okay? Thank you.
Yeah.
It is really interesting, isn't it? Because as an audiologist, when you're assessing a patient, and they come to you with a vague idea of what their symptoms might be, they might have Googled their symptoms, and typically they will sort of think that they have maybe hyperacusis, or even potentially be mistaken it for misophonia or phonophobia. But actually, it is this noise sensitivity, and it is almost like there isn't a lot of research around hyperacusis and sound sensitivity in general, but noise sensitivity is that sort of like little bit. It's all the way over on the other side as well, isn't it? What do you think we need to do do we need more research into noise sensitivity?
Yes, definitely. Well, as I was saying, we kind of conceptualize noise sensitivity on a normal curve, with some people being at the high end. And we could just accept that some people are more noise sensitive, and that's how it is, but the thing is that we get patients in the clinic and who are very bothered by noise. And as audiologists, I guess it would be our job to have solutions for those people. And from now on, we've been mostly categorizing those patients as having intolerance to sounds or hyperacusis, or a more umbrella term. But I think that categorizing it as noise sensitivity and knowing the mechanisms and the best way to treat it would be useful. So yeah, I would like to continue the research on that subject, as well as hyperacusis, which is very important. And it's not to say that some people might not have both, especially after a traumatic brain injury, for example. You see people who are very bothered by loud sounds, but also by continuous sounds in their environment.
Yeah.
So,
And also, there seems to be a strong correlation with neurodiversity as well in sound sensitivities. And it tends to be those types of patients who have the multiple diagnosis. They've got tinnitus, they've got hyperacusis, they've got misophonia. So it may well be that there's a noise sensitivity element in there as well.
yeah, yes, definitely. And we know there are a lot of there's a high prevalence for hyperacusis in autistic studies, in ADHD studies. But is it really hyperacusis, or is it how the authors defined the hyperacusis?
Yeah.
And especially in autism, there are varied definitions, and from what I've seen, this is not my expertise at all, but I did a scoping review on electrophysiological measures for hyperacusis. And from what I've seen is that autism studies sometimes didn't separate out what was over reactions to sound or under reactions to sounds, or so there is definitely a need for better characterization, so we know what we are studying, and we know, so we can compare studies between themselves. But yeah, it is definitely in the neurodivergence realms of research that we should continue in this field. Yeah.
In regards to, you were saying, obviously, the importance of being able to distinguish between these conditions is that then we can actually treat them as separately, and there may well be different management strategies for each. In terms of noise sensitivity, is there anything that you would recommend for patients?
That's tricky. That's tricky, knowing that we're in the beginning of um, understanding these conditions. And I talked about briefly about the noise canceling strategies and mild amplification. But definitely, that would be the first step, would be to consult with your audiologist to see what's the best trick for you, what's the best treatment for you. But I want to look in future studies in the benefits of using such technologies as noise canceling. We might say we don't recommend generally to use earplugs for a long period of time, because it might worsen the problem. You might get more sensitive, like wearing sunglasses for an entire day, you will get more sensitive to the sun. So
Yeah.
wearing earplugs for the day, you might get more sensitive. So what would be the risk of wearing noise canceling technology for an entire day? So that is to consider. But in certain situations, to get functionality, I think that we could benefit from mild amplification or noise canceling technology for people for which it is a priority and it is influencing their day-to-day life. Yeah, so that I would definitely look into that.
Yeah, it's interesting, isn't it? Because then you obviously always on a specific patient basis, isn't it? Because then if you have a patient who has tinnitus, they may not be able to wear earplugs because that might amplify their tinnitus. It's really obviously it's done by a case by case basis. On the tinnitus front, with new questionnaires, do you feel that there's a relevance in asking about whether sounds have an impact on their tinnitus? Because I have seen recently quite a lot of patients who aren't experiencing, well, I suppose they are experiencing discomfort from loud sounds, but their loud sounds is almost triggering their tinnitus. And so that's where they're experiencing the discomfort rather than a physical sensation. Do you think that the questions like that will be included in sort of new questionnaires?
Yes, good question, definitely. We know we've seen many patients that have this kind of triggering aspect of sounds and the effect the sounds have on their tinnitus. And it would affect management as well too. So it's definitely would be questions to add to new questionnaires, because we would have a more careful approach in introducing sound therapy, for example, with those kind of patients.
It would, I'd find it really helpful. When we do an assessment with Hashir International, you included some of the questionnaires in your slide that we use. But we start with the SSSQ, and that then indicates which questionnaires we then may ask a patient following. And for some patients, that means we're asking quite a lot of questions. And all of our patients are are really committed and are really willing to be able to take the time to be able to answer these questionnaires as open and honestly as they possibly can. But obviously, you do get that element of fatigue slipping in. So, something that can incorporate different elements of this, would be really beneficial for the patient as well.
Yes, definitely. Yes, we've had that problem as well. It gets tiring, and the thing is, patients will tend to get so tired of answering questionnaires, they won't look at the questions anymore, and then we don't get reliable data. So, as a researcher, I'm interested in having the more data possible, but I also want the valid data. And as
Yeah.
a clinician, I also want what's best for my patient and what will help him best. Um, so yeah, what you're talking about, having a protocol with the SSSQ as first to kind of screen what is the priority right now, I think that's the best approach, really.
Yeah. It's really interesting. So what are your next steps then? What's the first thing that you're like moving on to now?
Well, I will be starting soon postdoctorate studies to study the physiological markers of noise sensitivity and hyperacusis. So yeah, that's what's really interesting me right now,
Yeah.
and not just physiological, but also probably psychoacoustics. I'm still in the process of defining the project, but that's what's interesting me, and eventually I want to test new management tools and draw maybe I'm eager to see or to collaborate to an eventual guidelines for sound tolerance disorders. That will be really helpful. That would be
Yeah.
helpful.
Yeah. It all sounds really intriguing and exciting. And I know these things take they're a process and they take a lot of time. But I'm really excited to follow your work, and obviously you can share that with us as you go along. We'd really appreciate that.
Oh, that's nice. Thank you.
Thank you so much, Charlotte, for joining us today and sharing with us your presentation. We really appreciate it. Charlotte shared her email address in the presentation, and we'll include that one so that anyone that wishes to get in contact with you, that they will be able to. If anyone has any other questions, they can contact us through Hashir International. Hashir International would also like to announce the 8th International Conference on Hyperacusis and Misophonia, which will take place in Hanover, Germany from the 14th to the 16th of October 2026. The International Conference on Hyperacusis and Misophonia has established itself as the foremost global forum for advancing research, clinical practice, and patient advocacy in the fields of hyperacusis and misophonia. The conference has successfully brought together a diverse multidisciplinary community, including otorhinologists, audiologists, psychiatrists, psychologists, neurologists, occupational therapists, speech and language therapists, hearing aid dispensers, social workers, teachers, neuroscientists, and other allied professionals involved in patient care and research. Over the 3 days, attendees will be offered keynote addresses from distinguished panel of world-renowned experts, an interdisciplinary program featuring audiology, ENT, mental health, neuroscience, psychoacoustics, psychometry, and neurology. Insights from leaders in medical, surgical, rehabilitative, and mental health research, as well as voices of those with lived experience of hyperacusis and misophonia and their families. A specialist exhibition showcasing innovations in hearing care, therapy tools, and support services. Further information regarding abstract submissions, registration, and the full programme will be released soon. Thank you so much, Charlotte, for joining us today.
Well, thank you, Joanna, for inviting me.
Thank you so much, Charlotte. That was absolutely amazing.